Thanks very much, and I'm humbled to be here with the people I've known from various stages of my life for public sector for a long time, and especially with Chris Elias and Mark Dybel, who are people I respect enormously. Lois, who's just taken over at Global Health Council. So we've got, I did bring along a sidekick. Mitch Wolf is going to be the transition in our Office of Global Affairs at HHS. He's a senior civil servant there. Mitch was the CDC director in Vietnam and then Thailand, so also has a PEPFAR experience that's been expanded to global health. And I guess the first thing to mention is that Department of Health and Human Services is a major global actor, but that our systems and our thinking and our culture don't reflect that. And so HHS has, as you know, 11 very autonomous operating divisions such as CDC, NIH, FDA, Human Health Resources and Services Administration, Substance Abuse and Mental Health Services Administration, all of whom have global roles. And then we have 13 staff divisions that are under the secretary, and ours, Global Affairs, is the third smallest of those. So we have about 60 people of the 82,000 HHS employees. Over the last 15 years, HHS's foreign presence has grown from about 50 Americans posted under Chief of Mission Authority abroad to now about 600. And the PEPFAR program is responsible for the majority of those, but fastest growing for CDC has been global health security, but also immunization programs, disease detection, and certainly the surges, as there were thousands of CDC people who rotated in and out of the Ebola-affected countries and are now in Zika-affected countries and so on. So the sense that all of this is done as a one-off or as a surge, and that the sense of global health career track is one of the things that our office has tried to address. And I have to say, without marked success, we do not, because we have expertise in person, and we have HHS is a domestic agency in which we try to hire the best experts both in research and in public health and surveillance to respond to domestic priorities. This is very much what our authorizers and appropriators in Congress want us to do. This is a huge advantage, but in terms of hiring, also a little bit of a hindrance to our global presence. The paradigm seems, in my view, having been an ambassador a couple times in Africa and 30 years as a diplomat, and then moving the last 11 years full-time on health matters, but that the paradigm has changed, that a donor-recipient relationship with poor and lower middle income countries is very much last century, and that what countries, even the poorest countries, want in terms of relations with the United States are technical partnerships. They want the best people to find out how we respond to infectious and non-communicable diseases, how we look at systems, how we use data, how we organize the policy making, and to build capacity in those countries to be able to have a world standard of doing all of those things in the health sector. And that HHS it's a sweet spot for HHS, because as ambassador I realized that USAID and CDC had complementary strengths. If you want to move a large amount of money quickly, do not look to HHS. And USAID is much better at that, but their mechanism is that they're able to contract for it. And the contractors providing, in many cases, primary services are not building the local capacity in the same way that an alliance with our best technical experts in the country do. And in some ways, you can move the money quickly, but the actual response is delayed because it takes about a year to complete the USAID contracting process. So if you're meeting an immediate need, you first have you have to develop the request for proposals, you have to evaluate the candidates, they have to build their teams, they have to move their teams to Uganda or wherever, it's Uganda I'm thinking of. And if it really was an emergency, probably someone else has solved it or addressed it in that intervening year. So the value of having on the payroll with expertise in person great people is, I think, an emerging advantage to the United States. And I have to say that Ariel Pablos Mendez, my counterpart at USAID for the past few years, has said the same thing. The future is in technical cooperation. And so but the problems we have at HHS in organizing that follow some of the questions that you've posed for this session. One is, do we have the appropriate workforce? And the answer is no, there is no career track for global health in HHS. And that is in contrast, because we are a domestic agency, because we want that expertise domestically, we don't want to be a foreign affairs agency. We don't want to have a separate personnel system. At least I don't. I looked into this. I thought that was the way to go. I don't think it is, because I don't think we want a separate career track of people who spend most of their careers abroad. I think we want absolutely to have the domestic and the overseas presence of CDC, and in a growing way, fastest growing being FDA, which has large staffs now in India and China. NIH, especially the National Cancer Institute, has increasing presence abroad and contract representatives in a number of important countries overseas. That all of that expertise is valuable to us because they are our domestic agencies that are responsible for this and are able to integrate what we do domestically and overseas. At the same time, there's a tidal wave of young people who are getting Masters of Public Health degrees and are interested in international careers, and we have no entry-level places for them. Our office has a handful, and I have to say we get a huge number of applicants for a very small number of places just in an office that does policy and coordination. But the people who want to actually work in the field, USAID and the contractors who are USAID's traditional partners have historically been the entry level for global health. And that is drying up. The partners are finding local people who have the same qualifications as American kids. A third of the MPH students are international students, and in a place like Uganda, there is now a critical mass of Ugandans who can do what most Americans used to do as contractors. And so the career track, while there is a record number of people interested in these careers, well qualified to do it, if you want to help Kuwait set up a diabetes program, you probably have to be a diabetes expert, not a sort of generalist with a new MPH to come do that. So with apologies to many people in the room, Lois now represents them, but I see people who've been terrific contractors for U.S. government. The world is changing, and I think that one of the ways in HHS that I would like to respond to that is that we've been unsuccessful even in getting through our own budget office a backbone system so that we can support overseas personnel with language training, with the ability, training float. We have a quarter of our CDC positions vacant almost perpetually over the past decade. So to be able to get people in place, to be able to fill hard to fill positions, but also to support them if a post is evacuated. State Department, USAID have a family support office. They have apartments in Northern Virginia waiting for evacuees and a system there. CDC people are on their own, and they do not have that same support. There's nobody who's a career counselor for them. There's not someone who's an employee advocate. So we had a whole scheme for about $13 million. We thought we could bring us into the 21st century of being an overseas workforce. But that, as I say, did not even get through our own budget office, let alone to OMB or to Congress. So as you're looking at ways of making HHS more mobile and better able to respond to global health challenges, I think that the workforce question, which was on your list of questions, is really a key one. Also, I mean, Mitch can certainly talk more authoritatively than I can. Countries like Thailand and Vietnam very much are looking to us for a wide variety of questions which traditional bilateral assistance programs don't talk about: road safety, vaccines, tuberculosis, environmental health, NCDs, vital registration. These are things on which we do have some expertise, but I'm not sure that we're aligned either as HHS or USAID or DOD or anyone else to actually respond creatively to those kinds of suggestions. Another question was, are we what about, are we organized adequately to address challenges that aren't single diseases like women and children's health and NCDs? I think all of us, talked to Jen Dye on the way in. Mitch and I are huge PEPFAR supporters. It was from my point of view as an ambassador, watch out what you wish for, because I said, if you let ambassadors and country teams actually pick partners, determine which U.S. government agency can best meet the need, and be accountable for results, that you'll actually get better program implementation and more results. And I think PEPFAR has been a great example that turned out to be a good way to move it. But you do have to follow the money, and I urge in terms of the vertical programs, the accountability for the money is important. And for things like NCDs or women's and children's health, I think the challenge of the next administration or the next decade is going to be mobilizing local resources. And it's something that USAID and PEPFAR are actively working on. Mark and the Global Fund have highlighted this. And the question of how governments and societies, private and public sector, organize themselves to meet health challenges in low and middle income countries is going to be the key, because I don't, certainly on the HHS side, and I think for the U.S. government in general, I don't see the actual envelope of money increasing. And to the extent that we've committed to disease programs, I think it's something that the U.S. can be very proud of. And the AIDS effort, the malaria effort, now with global health security, helping countries put in place the international health regulations that will, we hope, prevent the next outbreak like Ebola from becoming an epidemic, because there'll be basic surveillance and reporting protocols and other things in place. That these are important programs that have a specific definition, and we can tell if they're succeeding. I think health system strengthening is much harder to measure, and I think that the evidence is that it's very hard to give money generally to a basket fund or a sector program in health and see results that can be attributed to those programs. It's just my experience. I hope I'm wrong, but I think the challenge of these huge unmet needs on NCDs or on women's and children's health do need to be looked at in terms of what exactly is the comparative advantage of the U.S. and within the U.S. of our various global health agencies to work on that. The Global Fund and PEPFAR, and I know Mark will talk about this, are now so intricately connected and are working so well, I think, together, that the inability of one to meet its goals means that the other won't either. And that this is, it's a huge opportunity. We've done whatever all the commentators said. Why aren't we integrating our programs much more directly and really being sure that we're not duplicating, instead complementing each other? That is now so entrenched that we really are dependent on the success of the Global Fund in order to achieve our bilateral goals in AIDS, TB, and malaria. The chance that we can turn the corner on those diseases is certainly one of the great opportunities of our time. And polio, river blindness, guinea worm, and other things that can actually be eradicated are also opportunities we really can't miss. If we drop the ball on those and the three Global Fund diseases, we will have let down our generation of people living with or at risk for those diseases. So there are lots of questions inherent in what you were talking about. I guess I have a couple just sort of final thoughts. One is, the question is, why aren't some things in terms of coordination working? And I'd say follow the money. It's disappointing to me that in the 5% set aside, for instance, for Global Fund technical assistance, that in the appropriations language says goes to USAID, that has been a decade-long struggle for anyone outside of USAID to be able to share in that money, even when we know that we in HHS have a comparative advantage in a number of the areas where the Global Fund technical support is needed. Similarly, the PEPFAR model, where state controls the money, but it is within the law that it should be divided among a number of federal agencies, from my point of view, has worked. It provides accountability, but it also provides that you have to have interagency involvement in order to fulfill the mandate. I think the PMI is a little bit different in that USAID has all of the money, and it's not even in the language that they should look for comparative advantages with CDC. And I think it's been a weakness of the program that there isn't a clear sort of statement that the money should be distributed based on the technical ability to achieve the goals of the program, not necessarily just where the appropriation lies in the appropriations bill. So I've tried to cover some of the topics you asked for, some that are on my mind as we look ahead.